Basically, Dr. Amit Langote already spoke about obesity and CKD, so I'm not going to go into that. But in practice, we've seen that bariatric surgery does help to improve metabolic syndrome and also to a large extent helps reduce comorbid conditions that enhance the progression of kidney disease. We've also seen that with bariatric surgery and weight loss, it also improves patients' chances of being on the kidney transplant list. And in obese transplant patients, it may also reduce the obesity risk factors that include sort of graft dysfunction. However, I must confess that managing CKD patients post and pre-bariatric surgery is probably every nutritionist's nightmare. And we draw upon a lot of experience and clinical judgment to manage these patients. And until very recently, there haven't been guidelines to help us sort of navigate through with these patients. But there has been a recent set of guidelines, or rather a review paper that was published late last year that sort of just gives you perspective in terms of how you can manage these patients. Starting from the preoperative evaluation, I think it's very important, number one, for us to get baseline biochemistry, because this will help us manage the nutritional status of patients, not only in the preoperative diet phase, but also help us manage their nutritional status post-operatively. It will help us manage and calculate calorie requirements so that we're not sort of looking at malnutrition or protein energy wasting. Very important, especially for dietitians in the field, to understand that we have to make sure we calculate weight, but make sure we record weight that is dry weight or edema-free weight, because that can be can make your calculations go askew. And though we don't really have a single strategy to assess the malnutrition in these patients, just the global subjective global assessment is probably good enough to understand where your patient stands in terms of malnutrition and wasting, even before getting them on for bariatric surgery. Before bariatric surgery, all patients are meant to undergo a compulsory diet in order to shrink the size of the liver, so that the surgery is easier, causes less complications, and also is easier for the surgeon to access the stomach. This diet primarily is a high protein diet, a liquid diet, and very low in calories. However, when you have a patient that is suffering from CKD, it is important to adjust your protein levels, and about 0.6 to 1 gram per kg ideal body weight is good enough to manage these patients preoperatively. And I think the important thing in this case is to avoid unnecessary restriction or to be too restrictive, because that is again going to reduce your lean body mass. Potassium restriction only required if there is any sort of electrolyte imbalance, otherwise not to sort of be overly restrictive in that. Sodium restriction only in the case of edema, and working with your nephrologist to understand fluid restrictions if at all anything is required. Now, post-operatively, there are a few considerations as well. Please understand that post-bariatric surgery intake, appetite drops drastically. The initial post-op phase is very difficult for patients to manage overall nutrition, because there's a lot of food aversions. There is a physical restriction of food intake because of the smaller stomach size. Appetite drops down drastically because of the changes in a lot of the hormones. And it takes patients at least a good 3 to 6 months to adjust to the new stomach and adjust to eating patterns and understanding what they can and cannot tolerate post bariatric surgery. Now, given that you have a patient that's already suffering from CKD, you want to make sure that you're managing their protein levels well enough, because all patients post-bariatric surgery are given a protein-forward diet. We do rely a lot on nutritional supplements, especially protein supplements, to manage their protein intake because of the drop in appetite and drop in intake as well. And most patients that do not have kidney disease also struggle to meet those requirements because of the nature of the surgery, and especially in the immediate post-op phase. And that's why we calculate their protein requirements at least from 1 to 1.5 grams per kg ideal body weight. And therefore, in patients that are clinically stable that are suffering from kidney disease, it is best not to over-restrict and manage at least about 0.8 to 1 gram per kg ideal body weight, primarily from high biological value proteins, and definitely rely on protein supplements to meet these requirements, because it's going to be very difficult to meet their protein requirements just via dietary intervention. Fluid intake again is very important and something that has to be taken very seriously, because of in the immediate post-op phase, there is that mechanical limitation to take in liquids. A lot of patients in the early post-op phase experience what we know as water intolerance, or they don't like the taste of water, or because of the size of the stomach, they're not able to eat and drink at the same time. So water intake does get hampered drastically, and that could lead to dehydration. And in addition, there is also cases of vomiting and nausea in the initial post-op phase because they're getting used to the stomach, and that can also cause dehydration. And therefore, very important to manage the fluid intake post-op, not only for patients suffering from CKD, but otherwise as well. So until and unless there is actual need for fluid restriction, make sure that your patients are getting at least about 1 to 1.5 liters of water a day, which might actually be quite a bit of a struggle for patients in the initial post-op phase, at least within the first month, because they can barely take about 30 to 40 to maximum about 80 ml at a time. So it has to be a constant reinforcement so that you don't reach a phase where your patient is dehydrated. Calcium and vitamin D, we do supplement all patients post bariatric surgery with calcium and vitamin D. Depending on the type of procedure, the dosage does change. So it would range from about 1,000 to 1,500 mg of calcium per day, from supplements, from food sources, everything together, and of course, even vitamin D3. Now, given patients that are suffering from CKD, they do have an increased risk of fractures. There's a decreased production and conversion of vitamin D to an active form, and also that hampers your calcium absorption. But we also have to make sure that we don't give them an excess of calcium in order to avoid hyperkalemia, and also to make sure there is no calcification, and therefore a slightly lower dose, maybe around 800 to 1,000 mg from all food sources would suffice. Most of our patients, whether they are suffering from CKD or not, do come in with extremely low vitamin D3 levels, and this we catch in the preoperative phase as well, when we check their baseline biochemistry. And most often than not, we have to sort of give them a very strong dose of vitamin D in order to boost up their levels. And given the fact that the patients suffering from CKD do have a higher risk of fractures, we would need to make sure that the vitamin D3 levels are at least around that 30 range, because we do see patients who come in with vitamin D levels with as low as 5 and 6, which is quite difficult to manage with only oral supplementation. So we do prescribe intramuscular injections as and when required, maybe on a fortnightly or on a monthly basis, in order to just boost that levels up, and then manage them with an oral vitamin D supplementation to keep those levels at an optimal rate throughout. Phosphate, until and unless it is really required, we don't have to add on another set of restrictions for patients suffering from CKD. And I think the easiest way to manage phosphate levels is to make sure that patients are avoiding any foods that are highly processed, avoiding foods that have too many food additives, because that sort of has a lot of your inorganic phosphate that gets absorbed and retained in the gut. And as far as possible, try and utilize phosphate binders in accordance with what your nephrologist would guide you with. Now, sodium again is restricted in most patients that are suffering from CKD, and the levels sort of remain the same whether it's with bariatric surgery or after. If there is no overt cardiovascular disease, then less than 3 grams per day, and if there is some sort of a heart issue, then at least about less than 2 grams a day. Of course, keep a close watch on the electrolytes to make sure you're constantly having a look at the labs and the reports in order that you don't reach a stage of hyponatremia, and obviously look at your fluid intake as well at the same time. Now, potassium, again, until and unless you actually have a case where your potassium levels are extremely high, best to avoid excess restriction, because please understand, and again reiterating that post-bariatric surgery, very, very difficult for these patients to manage their food, to manage their nutrition because of the small size of the stomach. And even, as dietitians, sometimes we try to be overly careful and overly restrictive to manage levels. But please remember that even if your patient is consuming some, potassium-rich food, it will not be in quantities that would actually raise the potassium levels that high, because quantities are extremely, extremely low post-bariatric surgery. So, for example, to give you an idea, in the immediate post-op phase, patients can barely manage a couple of spoonfuls of food at a time. That does increase to at least about, a bowl full of food, in the first 2 to 3 months, and then they eventually manage to eat approximately 50 to 60% of their original intake. But in the early post-op phase, the diet intake is extremely restricted. More often than not, they have a lot of aversions to a lot of food. So you have to sort of play around to what they can manage, what they're tolerating, and sort of hold yourself back from being overly restrictive, especially when it comes to specific nutrients. Iron again is an important nutrient that we supplement all of our patients post-operatively, and the dosage ranges depending from surgery to surgery. Overall, you would give them about 40 to 60 mg of iron post-operatively, and this can continue for patients that are suffering from CKD as well. But most often than not, these might not actually help to keep those iron levels at an optimum level. And you probably would need to administer an IV iron injection to be able to get those levels to optimal levels. And this is something, again, that you would prescribe or sort of look at after consulting your nephrologist to see whether this patient does require an IV iron to manage their levels, because iron levels do get affected quite drastically, irrespective of the type of surgery, whether you're talking about a sleeve or your bypasses or your OAGD, because of obviously the lower intake of food, but also because of the reduced amount of hydrochloric acid, because you're either resecting part of the stomach or you're bypassing part of the stomach, your iron absorption does get affected. Specific salts of iron are recommended post-bariatric surgery, so you would look at giving either your chelated forms, or either your ferrous fumarate or your ferrous glycinate, and not the routine ferrous fumarate, because it doesn't get absorbed as efficiently post-surgery as it normally does. And unfortunately, most of the iron supplements available in the market are of your ferrous fumarate sort of variety. So it's important to also check what sort of iron is available in your supplement in order that your patient actually gets the most out of that supplement. Multivitamins are prescribed for all patients, again, post-bariatric surgery, and depending on the type of the surgery, we would prescribe either your routine multivitamins, maybe about 2 or 3 tablets a day, or if you have bariatric specific multivitamins, then you adjust the dose accordingly. Your multivitamins, calcium and iron are nutrients that you would start off in the immediate post-op phase, say about 1 month post-bariatric surgery, and continue them for at least 3 to 6 months post-op, depending on the surgery. However, most of your bypass procedures require supplementation for life. So it is very essential that even patients that are suffering from CKD are given multivitamin supplementation, but because there are chances of sort of accumulation of certain fat-soluble vitamins in patients suffering from CKD, it's important to check the amounts of at least your fat soluble in your multivitamin formulation, so that you're not exceeding levels and risking yourself of toxicity. So vitamin A is something that you want to keep a watch out on. Vitamin C, again, is something that you want to check so that you're not sort of risking, formation of calcium oxalate stones. So make sure that you have a good history of your patients so that you know whether they are at a risk of developing stones, and then look at your multivitamin formulation to check that your vitamin C doesn't exceed the routine RDA for for the population, so that you don't have another problem on hand. Follow-up for these patients probably are more the post-bariatric surgery. The follow-up routine is, week to 10 days post-bariatric surgery, then at 1 month, and every 3 months until they complete a year. And then an annual follow-up is required post all types of bariatric surgery. However, in this special subset of patients, you would want to have more routine follow-ups, more close monitoring. Make sure you're looking at their labs more routinely than you would any routine bariatric patient, because your levels could change quite frequently, especially in the immediate post-op phase. You want to make sure you're looking out for signs of dehydration, for edema, for malnutrition. So these special set of patients will require more of your attention post-op. So it's important to identify these patients in your pre-op phase, so that you know that they will require more close follow-up and monitoring, especially in the immediate post-op phase. So at least for the first 3 months, they would require more close monitoring than routine bariatric patients. So in conclusion, we do know that bariatric surgery can help with managing metabolic syndrome, but we have to remember that this special subset of patients do have specific nutrient needs, and we have to keep in mind the type of surgery that has been done and manage these patients based on individualized lab reports and not just general understanding of bariatric surgery and bariatric nutrition. We have to make sure, especially as nutritionists, to avoid unnecessary and severe restriction in order to prevent malnutrition and prevent excess loss of lean body mass. Work closely with your patients, monitor them very, very closely. And please remember that in case of all bariatric surgery and bariatric management post-operatively and pre-operatively, it is a team effort. You do need a very strong multidisciplinary team approach. You obviously will require a surgeon, but work very closely with your nephrologist, and preferably a nephrologist that does have an understanding of bariatric and has treated bariatric patients before, because your nephrologist and the nutritionist will work very closely together to manage this special subset of patients. And lastly, we definitely need more data, more research out there to manage these patients in the long term. Thank you very much, and I hope I've kept